Okay, thanks. Okay, so I'm going to talk about supporting exclusive breastfeeding in the early days. So one of the things I'm going to be talking about is Unicef baby-friendly practices in the UK, which we follow in our hospital. Next slide, please, Justin. Okay, so I work, sorry, by the way, I'm 9 months pregnant, so I'm trying really hard not to go into labour right now. So I'm trying to get my breath when there's a baby pressing on my lungs. Okay, so I'm going to talk about my background, my current role and responsibilities. I work at Whipps Cross Hospital in East London. What is baby friendly and how baby friendly practices work. Quality improvement project I started, and then I'm on for stage 3 baby friendly planning and my top tips for establishing breastfeeding in the early days. Thanks. Okay, so I don't look like this anymore. I've been working in the NHS for 10 years. I've had a range of different roles. I don't know that I move around a lot, but I was firstly a neonatal nurse, adult trained, and then a neonatal nurse, pediatric immunisation nurse, then I trained as a midwife. So I was a staff midwife for a very short time, and then became public health midwife, which was a short project, and then infant feeding research midwife, which was a 9-month project. And then practice development nurse, I moved into education for 3 years. And then in January this year, I moved into the current role of infant feeding lead. So my role as baby friendly lead is predominantly a training and education role. So what I deal with in my role, so I think the way that different hospitals do it quite differently. All different hospitals might even in the trust that I work in, there's 3 infant feeding leads, and we all do it quite differently. So my main point is that I work in dealing with complex infant feeding cases, from antenatal all the way to postnatal, which is multiple births. So I see like most of the twin ladies, any babies who anticipate premature or small for gestational age, a woman who've had previous breast surgery and worried about breastfeeding, I'll see them antenatally, and then all the way through until they go home about day 1, day 2. I deal with antenatal classes. I carry out baby friendly audits, which is a huge part of my role. Complaints and serious incidents, unfortunately, is part of the role. Not a huge amount, but there are some that I do have to deal with. And then most of it is a lot of training. So when I started the role in January, I commenced training programs for a whole host of different healthcare practitioners, from doctors, midwives, maternity assistants, the hearing screening staff, because they're working on the postnatal ward, neonatal nurses, pediatric nurses, and then a lot of students. I think what's been quite interesting doing that is the question that I always start with is, how would you rate your infant feeding knowledge? I always start a presentation like that with staff, and it's really quite interesting because the students will rate themselves 6, 7, 8 out of 10, and the paediatricians and the paediatric nurses rate themselves 0 or 1 out of 10. And when I explained that to some students a while ago, I said, how do you think that a paediatrician would rate their knowledge of infant feeding? They went, oh, 8, 9, 10. I went, 0. In a whole 5-year degree in medicine, in the UK, they generally get 0 information on breastfeeding and infant feeding. And that's quite a worrying factor, I think, because these are the doctors who are making feeding plans for babies, or giving women information. So women will generally listen to a doctor more than she would probably listen to a midwife or maternity assistant. So we can spend like hours and hours helping women and giving them all the right information, and then a doctor will come along and say, oh, well, why don't you just give a top-up? Won't do any harm. So I think one of the baby-friendly practices, which we'll go through in a minute, is a lot about mixed messages and how training is really, really important, because it stops the mixed messages. And it's really important for us all to sort of say the same information. So some hospitals have infant feeding team, and some just have an infant feeding lead. I personally think there's pros and cons for both. So for example, in my hospital, it's just me, but I would say that my job is to empower staff to support women. So I'm there for complex cases and for advice. My job is not there to be an extra pair of hands on the ward. I think staff have an expectation that when women require feeding support, that's for me to carry it out, but that's not the case. They do often call me for basic position attachment issues that they can help with, and they sometimes don't call me for specific cases where they really probably do need my input, like weight loss or jaundice. But I think, so with it just being me in my hospital, I have to choose where I can support the staff and empower them. Whereas my counterpart in one of our hospitals within our trust, they have a team of infant feeding staff, generally band 3s, band 4s, maternity assistants. And that can be an issue because a lot of the staff will say, oh, wait for the infant feeding team to come in. And then they don't actually help the woman at that precise minute when she needs the help, which can cause a problem. So I would rather empower all the staff, so when I'm not there, they can carry out and give all the right information and support. I think that generally makes a difference. So a lot of the hospitals in the UK do it quite differently in each hospital. But I think there's pros and cons for each way. Because what one of the issues we don't want to happen is for the ward staff to get de-skilled in infant feeding because they rely on the infant feeding team or the infant feeding lead, and that can be an issue. Also part of my role is I liaise with the practice development nurses for A&E, so they're the education nurses for A&E, the neonatal unit, maternity and paediatric ward. The neonatal unit, which is just this floor below me, so although I'm not responsible for what they do, they have an infant feeding nurse, a band 6, who supports parents within the unit, and we work quite closely together. I don't have their infant feeding rates, but they do have access to donor breast milk, which I think is really fantastic option for parents. So I generally will support them, and if she's not around, I'll go and offer some help. But it's generally about information and training regarding all different areas around the hospital. I always think that although maternity within my maternity unit, we do give a lot of infant feeding support and really quite good support and helpful. We are baby friendly stage 2 within our hospital. Within maternity, outside of maternity, we're not. So I'm not responsible for, or there's no guidance for what the A&E staff or pediatricians in A&E or children's ward and things, the information that they give, they're not baby friendly. So I've started doing teaching for the pediatric nurses and A&E and the pediatric doctors and the children's ward, because I think that if a woman has a poor sort of breastfeeding journey with the first child, she's less likely to attempt it with the second child. So for example, we might give all great support in maternity and everything's going great, and then for whatever reason she turns up on the children's ward and they put baby on a strict feeding plan, and then breastfeeding, she ends up stopping breastfeeding before she wanted to, because of the information or support or advice that she got within that unit. I think that can really affect things. So I think part of my role is I want to really expand and go across the whole hospital so that everybody gets the same information and support whoever they're coming across. Is one of my aims for the future. Next slide, please, Justin. So I work at Whipps Cross, which is part of Bots Health Trust. It's the largest trust in London. It has a current birth rate of around 4,000 per year. Our breastfeeding rates are on average about 64% initiation at birth. So I put a little star there because that's not a true figure. And annoyingly, the reason why it's not a true figure is because we have around 80 to 100 babies every month that's not recorded on our system. So that affects our rate. So I can't tell exactly what our rate would be. I'm guesstimating it's over 80%, but I can't say for sure because of a huge number of babies that are not put on the system. And the reason for that is staffing that they're not used to our system, agency staff. They don't know how the computer system works, or babies didn't have their first feed with the midwife who actually delivered the baby, who did the computer work. So if baby was born at 7 p.m, midwife did the computer work, and then the next midwife didn't realize it hadn't been documented, that's why it doesn't get documented. So currently our initiation rates are shown at 64%, but I would say they're much higher than that, I would guess. And we have a BFI training program for all staff, it's a baby friendly initiative. And we are stage 2 baby friendly, which we achieved in May 2019. So we should have been going for stage 3 2020 or this year, but because of COVID and the previous infant feeding lead leaving, and now I'm on maternity leave, we are a bit delayed, but hopefully we will be going for early next year, and that's the plan. So I've been working for the last 9 months going through assessing our stage 2 and then getting ready for stage 3, which I'll go through in a sec. Next slide. Okay, so we've probably all seen this. I'm hoping you might have seen this. This is just taken exactly from the Unicef breastfeeding rates in the UK. Most people are probably aware of it. So this was from the infant feeding survey that hasn't been completed since 2010. I think that's a huge issue that we haven't done it since 2010. I think that just shows that probably not really a priority. We should have had one. But basically, this is what we're saying, is that our breastfeeding initiation rates in the UK was 81% at birth. And then as we go down to 6 months, only 1% of babies are exclusively breastfed. So this is from the UNICEF page. So what UNICEF recommendations are, or guidance, is to sort of help support to increase these statistics. Because what they say is that 8 out of 10 women stop breastfeeding before they want to. So my job is not to force all women to breastfeed, it's to support them in their choice and for them to make an informed choice. But most women choose to breastfeed, and for whatever reason, they generally stop before they plan to. So looking at UNICEF guidance, that's what one of the things we wanted to do, was to increase breastfeeding rates in the early days. Next slide, Justin. So I started a quality improvement project back in January when I started my role, and it was looking at to increase breastfeeding rates at discharge, because our initiation rates are pretty good. But then within a day or two before they go home, they generally go home between day 1 and day 3, most women will go home from the hospital. And our breastfeeding rates had decreased. Our mixed feeding rates had gone up quite a lot. And that was a concern. So what we have to think about is, why are women introducing formula within the first 24 hours? So I wanted to look at a quality improvement project to see if we could increase breastfeeding rates at discharge from the hospital, so basically reduce the mixed feeding rate. So when I commenced the role in January, there'd been a gap of about 4 months since the previous lead had left, and the breastfeeding rates on discharge were about 44%. So I set up this project and organised a team of colleagues who had an interest in infant feeding, which included a diabetic specialist midwife, newly qualified midwives, experienced maternity assistants, postnatal ward manager, and community midwives. So we could all meet together and look at why were our breastfeeding rates so good at birth, but then why did they drop quite a bit? On reflection, I probably should have had a neonatal doctor and a nurse, but COVID, staffing, things like that at the moment were an issue. So we all sort of met weekly, and we gave tasks to each other. And one of the community midwives looked at reasons why antenatal conversations were not happening. And the diabetic midwife looked at the number of women who were given harvesting colostrum packs, and how many of those were actually women actually brought them in for birth and actually started doing it. So, and also looked at during postnatal conversations, should have a chat about, you were given a harvesting colostrum pack, did you use it, did you not, did you find it useful? So that's still on, those projects are still ongoing. And one of the newly qualified midwives carried out an audit to see how many women in the postnatal ward have been offered a feeding review prior to discharge. So our trust policy is that women should have be offered a feeding assessment within 6 hours of birth and prior to discharge. And this doesn't always happen for many reasons. So that's something that an ongoing project that we'll be looking at as well. And then, so within a few weeks, we'd already achieved the 40, we'd gone up. So the plan was to increase by 10%. We actually went up to 65% within a couple of weeks. I don't know if it was just my presence on the ward, but we did. And now it's still standing at about 64%. So some of the things that we did in the project, sorry, Justin. Right. So what I did was we had infant feeding champions. So I started with 2 in the antenatal clinic who would give out the harvesting colostrum packs and talk to all women about breastfeeding, give them all a leaflet and a bit of information. And then 3 champions on the antenatal and postnatal wards. And then I started introducing harvesting colostrum workshops. So I'm still doing virtual classes, and I think virtual classes actually works really well, because you can get more people into a virtual class and they don't have to go and find hospital parking. So I quite like the virtual. So I do harvesting colostrum workshops, 30-minute class, which I do live. twice monthly, and 2-hour breastfeeding masterclass twice monthly. With the Harvest and Colostrum workshop, I'm a huge advocate for Harvest and Colostrum. Feel free to ask me any questions about that if you're not sure what that is. But that's something that hadn't been done in our hospital before. And a lot of the diabetic midwives would give out the pack, but then women wouldn't do it. I think they didn't really understand how to do it. And once they've tried a couple of times, it didn't really work. They just sort of gave up. So I started the virtual workshop twice monthly so that they could just come on and say, I've tried it, this isn't working, what can I do? And then I give a bit more information, a bit more support. And also relieves a bit of pressure off the midwives who are giving out the packs, but actually that I can sit and go through it with them in more detail. And that's been really successful. Also put on posters and leaflets. When I started in the unit, there was not one poster on the postnatal ward about breastfeeding. So that was something that I introduced pretty early on. And a community board. Postnatal support is really important. And there wasn't any information about where people can get help and support in the community. So I just introduced a community board with all the infant feeding teams in postnatally in the different areas, the different boroughs that we cover, just so people get more information. And I commenced a referral pathway for local postnatal infant feeding teams. So when women go home from the postnatal ward, we offer them a referral to the infant feeding teams. They will call them within the day, generally within a day or two. So that women who might be a bit reluctant or going home thinking I'm a bit unsure about how this breastfeeding malarkey works, they know that they've got the infant feeding team calling them as well as the community midwives. That gives them a bit of extra support. We also have Twitter and Facebook pages and MTT training, multidisciplinary team training. So our breastfeeding rates of discharge increased quite considerably, but there's still a bit of work to do because it's only 64% right now, but we'd like to increase it a bit more. But and then obviously you'll have to work with the health visitor team to see if it's carried on past sort of like a few weeks when it really generally goes down. Okay, so Justin, thank you. So effect on breastfeeding rates. So our breastfeeding rates are what I think is about 80%, but I would say why they're not as high as what we probably expect them to be. I would say COVID has had a really dramatic impact is in regards to our staffing levels. New staff had started and for months hadn't received any training. Our postnatal drop-in was cancelled. So normally we have a postnatal drop-in on the postnatal ward, say every morning at 10 o'clock. Women can come along to our discharge lounge and have like a half an hour talk with our maternity assistants and go through a bit of extra support and breastfeeding. That's generally quite successful. So we're looking to bring that back very shortly. Antenatal education, obviously it changed from face-to-face to virtual. So that probably affected things as well. Because all my classes are fully booked, but I probably only do about 30 a month. And our birth rate is about 350 a month. So I know a lot of those are not going to be first-time parents, but that's still quite a low amount compared to how many women we have. So that's something that we need to look at increasing because it's really important. And we do have a formula feeding culture in the UK, and especially mixed feeding. Formula is seen as just as good, and that's something that we need to deal with. But I think our mixed feeding rates have gone down quite a lot in the last few months, and that has made a difference. Because I do feel that if women introduce formula in the first 48 hours, they are much less likely to get back into breastfeeding. So it's really important in the early days for staff to really be supporting women with their choice to breastfeed, and not for women not to be introducing formula in the early days would really make a difference. So what I feel is that breastfeeding needs to start, the information on breastfeeding needs to start way before birth, if not before pregnancy. So Unicef have a guidance on antenatal conversations, which I'll discuss in a minute. But there's a section in our antenatal notes which needs to be signed off during pregnancy to show conversations have taken place. Because I find some women, when I do the audits, I find that women will say that they haven't had any conversations about infant feeding for their whole antenatal period. And it's basically like they turn up in postnatal ward with a baby and go, right, now tell me everything about breastfeeding. Well, it's too late then, because they're not really able to make an informed decision at that point. It really needs to start either before pregnancy if we can, but really beginning of pregnancy at booking, so like at 8-9 weeks, and start giving them bit by bit information about breastfeeding and skin to skin and how to get breastfeeding off to a good start from the very beginning, so that by the time it comes to being here, they've got all that knowledge. Because I think one of the reasons why they introduce formula, women choose to introduce formula, is because they don't really understand how breastfeeding works. And I've had many conversations with women who introduced mixed feeding in the early days, and I'll say why, and they'll say because I don't have any breast milk. And I go, but you do. And then we have a conversation, and she literally doesn't believe me.
5 minutes, Louise.
Does that include question and answer time?
No, then I'll give you a few minutes for questions then.
Right, okay, good. Yeah, and I think it's not quite, they were not in the right frame of mind, can't quite take that information in at that point about how breastfeeding works. It needs to be much, much, much earlier. So I always say that I can't fix the issues that are on postnatal ward, as in women bringing in their own formula and giving it, that sort of thing. It needs to start antenatally, and that's where I generally try and focus my time, is helping women antenatally and doing antenatal classes and helping the staff give out the information antenatally is really, really important. So one of the things that I talk to the staff about, which is a Unicef guide, is not to say the question, how are you planning on feeding your baby antenatally? Because it doesn't matter. They don't need to make a decision at that point. All we want to do is to give them information about breastfeeding and answer their questions so they can make an informed decision. And if it comes to postnatally, they're choosing to formula feed, then we give them the information about formula feeding and how to make up the bottles and all that sort of stuff. But antenatally, just give them the information. But people have to keep giving the right information and keep giving it regularly. They can't just mention it just once. And everybody needs to be saying the same thing. It does make a difference. And I think the problem that we have here is that we have a formula feeding culture and a lack of long-term breastfeeding in England. I remember speaking to a doctor a while ago, and I was saying about we don't have a culture of long-term breastfeeding in the UK. And she went, well, why do people still breastfeed at 6 months? And she went, actually, in other countries, you start feeding them much earlier. So what's the point of breastfeeding at 6 months? And that's a pediatrician. If a pediatrician thinks there's no benefit to long-term breastfeeding, then why would women think that? So we need to change the culture for everybody, that the effects, the benefits of breastfeeding are far more than what we generally actually speak about. And the problem is that we've got an issue here when, women in their families probably haven't seen anybody breastfeed. And, it's happened over the last 40 years, but formula feeding generally becomes the norm in lots of households. And children grow up not having a positive role models in relation to breastfeeding. And that's something that needs to change, but it's going to take time to get back. Justin? Thanks. So Unicef baby friendly standards. So we should, this is what we introduced. So pregnant women are prepared, we have closeness and feeding straight after birth, breastfeeding is off to a good start, informed decisions regarding other foods for babies, and close and loving relationships. This is something that we work on. Justin, so I'm trying to fly through the next one so I don't miss the question. Okay, so I carry out audits, lots and lots of audits every month with women, staff and supplementation rates, and then I share them quarterly with the teams. And our results need to be over 80% for UNICEF to assess us for stage 3. So we're not quite there yet. There's 3 main issues that we have. These are areas for improvement, and it's for mothers to know the sign of effective feeding, mothers to know about responsive feeding, and mothers given information about sources of help and support. So when I do the audits, these are things that we don't always score so well on. This is why antenatal education is so important, because if we can give that information, just those 3 main points antenatally, then they'll understand how it works. But things about responsive feeding, they seem to think that babies need to be fed at set times, and that's not the right information. So they don't generally understand how it works. That's why I think a lot of women will end up giving formula. Next one, thanks, Justin. So this is a page in our antenatal notes. Basically, it's antenatal conversations that need to be discussed. And one of those questions is about feeding your baby. So we have to give all this information. And some of it is just about safe sleeping, antenatal education, connecting with your baby, skin to skin. All of these aspects need to be discussed in several appointments throughout the antenatal period. So the aim is by the time she gets to birth, she's got all this information. And it's given alongside these apps that we have and these leaflets that UNICEF make, and also my antenatal education classes. So it's really, really important for all the information to be given antenatally. Okay, Justin, thank you. Okay, so stage 1, building a firm foundation. So we have several trust policies in place which give guidance in infant feeding. So what I do is I make sure staff are aware of all of these policies when they're first starting their role, during their 2-day baby-friendly study day, and also during the yearly mandatory training update. So these policies I reiterate to the staff quite a lot. It's really important. One of the issues that women say that mixed messages, when one person says something and one person says something else, is really frustrating to them. So if we can all follow the trust policies, then we'll all give the same information, and that does really make a difference. Next one, thanks. I'm not actually looking at what slides you're showing, I'm looking at something. That's good. Okay, so in regards to infant feeding policy, in regards to advertising, sale, distribution of materials to promote breast milk, feeding bottles, teats and dummies in all areas of facility, so that's prohibited. And also attendance to study days funded by formula companies is prohibited. And also in regards to giving out formula in the hospital, we only give it if it's clinically indicated. So women will know that if they're planning on formula feeding, we're not providing it. So they need to bring it in themselves. They normally bring in like little ready-made packs, and we will only give it if it's clinically indicated, which is quite rare cases. Really, really, really low blood sugars, but generally colostrum will fix most things. And we do have a milk kitchen that they can use if they want to bring anything in. That's fine. We also don't provide bottles and teats. So if women are choosing a formula feed and only bring in the formula, they need to we'll give one, but they need to bring in the rest. We're not going to provide anything for them. We provide them with support for breastfeeding or support for formula feeding, if that's how they choose to. But giving them the formula and the bottles and teats doesn't really help them. If they're choosing to make an informed choice, then that's fine, that's their decision. But we have a policy in our place in our baby-friendly hospitals that we don't provide it. And then if we have to deliver it because it's clinically indicated, then it has to be documented, and then I will assess the situation. And that's part of my audits for baby friendly as well.
Thank you, Louise. The time is now up. That's such an interesting conversation that we've had with you there. Louise, telling us about your hospital and how the breastfeeding rates have increased. And I'm really impressed to hear that you actually don't have formula milk in your hospital, that women can bring in formula milk and it's given if it's clinically indicated. Did you have some challenges with that decision that formula milk is given if it's clinically indicated?
It was done many years ago, way before I was around.
Okay.
But even though I came into the role in January and the infant feeding lead left last August, I reiterated this policy, and a lot of staff were like, oh no, I can't not give it because I'll get a complaint. And the head of midwifery said, we've never ever had a complaint of saying we don't provide formula, because they provide everything else for themselves. They bring in their own, their pads and, all these other things that they do. So they understand that it's expected of them to bring it in. So no, not really any challenges. The staff worry that someone might shout at them, but generally when we explain the reason why we don't, it's fine. And nobody really has any issues with it. It's quite normal.
Thank you, Louise. I'm just looking at the questions here now, and the questions come in. How do you avoid becoming an extra pair of hands on the ward? It's something I hear from my hospital colleagues.
So generally when my office is on the postnatal ward, so generally staff will come in and go, oh, hi, can you just go and see the lady with the flat nipples and bed tray? Which I hate that statement. And I say, why, what's the issue? And I'll generally talk them through it. And so it's just about being a little bit more sort of stern with it. I pick and choose which cases I will go to. If a woman stops me in the corridor, I will try and maybe answer her questions, but you just have to, otherwise you will end up spending all your time there. So it's just about being a little bit sort of hard on the staff and saying, no, it's your job, you're doing it.
Yes, and then I think the education sessions are very helpful as well that you're giving, Louise. Also, could I ask you how long would you spend with staff? Would it be half-hour sessions, quick teaching sessions?
So the infant feeding policy states that every new member of staff has to come and meet with me within their first week, and I have to reiterate the infant feeding policy to them. So that's generally about an hour conversation when they very first start.
Okay.
And then there's different training sessions. So with the pediatricians, that's generally about an hour. I run a 2-day baby friendly training for all staff must attend within 6 months of starting. That's 2 full days.
Yes.
So it's different sessions, generally different amounts of time.
Yes. Very, very good. Another question I see here is, why are the supplementation rates so high and increasing? It's the same here in Ireland, the drop between initiation and discharge rates. What are the main reasons for this, in your opinion, Louise?
So I find most women, so I have got the statistics, but I didn't put them on the page, generally have, so about, I think probably about 50 to 70 women might start introducing formula or mixed feeding within 48 hours of birth. And I would say it's because they didn't get the information antenatally.
Yes.
So I think a lot of women think that breast milk is just going to shoot out everywhere at birth, or that baby's starving, and they think that their breast milk's not enough. So it's generally, I would say 9 times out of 10, they're introducing formula because they haven't got the background information.
Yes.
Or they're not getting the support. So all we generally need to do is to reassure them. So our slow to feed policy says if baby hasn't basically fed in the first 24 hours, as long as they're well, it's fine. They can go 24 hours without having anything. But we don't reassure the parents and explain that this is quite a normal biological process and they're fine. They panic. The staff sometimes will say, well, fine, just give some formula then. But it's not helping anybody. We just need to give a lot more reassurance and information.
Yes, yes. I'm hearing a lot from you about the importance of antenatal education and the fact that you're giving breastfeeding classes and also the antenatal colostrum harvesting workshop. And could I ask you, are you encouraging just women with diabetes or all women?
All women.
All women, yes.
Every single woman should do it.
Yes. I have a question from somebody in the audience who said, what is harvesting colostrum? And we can certainly open that conversation again. But so every woman, Louise, you're encouraging every woman to express colostrum towards the end of their pregnancy, freeze it and bring it into hospital with them. I think that's wonderful.
Yes.
And the last question for you is, any tips to reduce supplementation in the first 3 days in a busy hospital?
Harvesting colostrum.
Harvesting colostrum, very good.
Antenatal classes. I always say the 2 main things, harvesting colostrum and antenatal classes, are the 2 things that we'll do, and staff giving support.
Yes,
and giving reassurance.
Fantastic. Thank you so much, Louise. It's been invigorating listening to you today, and we really do appreciate you speaking to us, especially as you are how many weeks pregnant now?
39.
First time. You're wonderful. Thank you so much, and I wish you every success with the rest of your pregnancy and your early breastfeeding experience as well.
Thank you.